Welcome everybody. My name is Dr. Julia Zając and I would like to welcome you at another Thursday webinar. Today our speaker will be Professor Regis Peffault de Latour, and he will be speaking about bone marrow failures, genetic diagnostic. A few words about today's speaker.
Professor Peffault de Latour. He has obtained his PhD in medicine at the University of Paris. In immunology from the Pasteur Institute in 2006, and trained in hematology at the Paris Hospital APHP, and in his postdoctoral fellowship at the National Institute of Health in USA from 2008 to 2010. He obtained his position as full professor of clinical hematology in 2014. He's currently working in the hematology and bone marrow transplant department of APHP Hôpital Saint-Louis, and he's in charge of the reference center for aplastic anemia and nocturnal paroxysmal hemoglobinuria and the French network on hematology, immunology, rare disease, marrow. He's also coordinator of aplastic anemia working group of the European Society for Blood and Marrow Transplantation, the EMBT, and he's coordinator of the bone marrow failure subnetwork for the ERN-EuroBloodNet. So, Regis, it is my pleasure to give to you the micro.
So thank you very much for this very kind introduction. It's my pleasure to be with you today. It's true that we are facing difficult times. As you see, I'm between the hospital and my home and trying to face what we can do as a hematologist with our background. That is not easy, but anyway, so we have to do this. I was thinking at the very beginning to cancel, and I think that it's not a good thing. We have to continue to live, to continue to learn, to continue to share, even if it's a difficult time. So basically what I'm going to speak about is BMF. That's my field. That's something I'm trying to develop from many years. And more than genetic disorders is really a diagnosis, is really to know how to work up a patient and to face when we should look for something, when we should treat. And this is the main of my presentation. So first of all, of course, there's disclosures that we have to do before speaking. Then the agenda. So basically, the idea was really to go with you in the next 30 minutes in the exams that might help, but also in the clinic. And what we're doing with facing the patients at the moment, there's many genes, many tests, and many messages that on my view is not always good, because we have to treat those patients in emergency. Aplastic anemia is really an emergency because patients have cell counts that are going down, and we really need them not to be infected and not to get so hemorrhage. So this is the reason why it's so important. So this is what we are doing in the reference center. So I will go through it and always trying to dissect the diagnosis between aplastic anemia coming from idiopathic causes or from constitutional disorders, and at the end we'll have some time to discuss. So the diagnosis really, if it's constitutional or acquired, is exactly the same. I would say that we are facing patients that have pancytopenia with most of the time macrocytosis. We don't really know why this is the case, but this is something very common. And we have most of the time also, constitutional or not, some thrombocytopenia at the very beginning. When you're facing pancytopenia, there is already something that might be helpful to dissect or to distinguish or to differentiate between constitutional and acquired disorder, is that when you have a acquired presentation, most of the time, this is brutal, this is acute, and the lymphocyte counts most of the time are preserved. While we observed in Fanconi patients or dyskeratosis patients, some lymphopenia or even some immune dysfunction. So this might be something that might be helpful. This is, of course, not very discriminant, but this is already something that might make you think that this patient is possibly presenting a constitutional disorder. So the bone marrow aspiration is exactly the same between genetic causes and idiopathic aplastic anemia. We don't want to see any abnormal cells, and you need the bone marrow to do the diagnosis. And as you can see here, again, you may have some signs coming from the pathology helping you to make the difference. There is, of course, hypocellular marrow. This is not specific. This is exactly the same between two diseases, both diseases. This erythropoiesis is something that is very common, very, very common, and it should not make you doing the diagnosis of MDS. This is something that most of the time is confusing in the literature. This erythropoiesis, isolated erythropoiesis, is a sign of is a sign. Might be seen in the case of aplastic anemia outside myelodysplastic syndrome. If you have abnormalities on platelets or white cells, neutrophils, then this is something that might make you think about MDS. But the erythropoiesis alone is something that might appear in aplastic anemia, whatever the causes is constitutional or acquired. We do know that in acquired aplastic anemia, you have some infiltrations with mite cells or with lymphocytes or plasma cells, macrophages. This is something that, again, might make you think more on the acquired side than the constitutional side. We know that in the repartition of patients, you will have 80% of patients with idiopathic aplastic anemia and 20% of patients with genetic disorders. And of course, the main, I would say, argument to think about acquired is the treatment. So, of course, just to say that this, when you will treat the patients, you will know if yes or not, if it was acquired. And what I would like to point it out now is to make you think, of course, before treatment, who should be screened and who should be targeted before going to immunosuppression that might confirm your previous views. So we do know that acquired aplastic anemia is mainly due to immune dysregulation. So there is many models. I'm not going to enter into detail. You can read any reviews. We think this is a Th1 causes, that Tregs might be involved with Th17 at the end. I was studying these cells, these subtypes, when I was at NIH. We have many reasons to think that the immune system is involved. We don't really know exactly who is doing what, but this is what we are targeting when we are treating idiopathic aplastic anemia. The PNH clone, this is something very important to make the difference between inherited BMF and acquired BMF. Just this scheme that is recapitulated what we think is happening. So basically, we have a normal hematopoiesis first. Then we have probably mutations. We have a mutation in PGA genes. And these mutations, if it's not in the context of immunological disorders, if there is no acquired bone marrow failure disorders behind, if there is no an immune attack in the marrow going on, these cells will disappear. So basically, if we are testing thousands of people, we will find some GPI negative cells, but then they will disappear with time and there won't be any idiopathic aplastic anemia. If there is idiopathic aplastic anemia, then the cells might expand, and you may observe at the end some patients with a aplastic anemia, PNH syndrome. So for me, PNH is a very important information that might, in a way, is a strong argument to think the patients you're facing is presenting with an acquired disorder. So this is not genetic, but that might help not to go to test patients that obviously have something else than constitutional. So, of course, now what we are feared about, what we don't want to treat with immunosuppression is those patients carrying genetic abnormalities and presenting genetic and, let's say, familial disease. So the main one is Fanconi anemia. This is the most frequent one. Since 15 years, 10 years ago, we are now describing more and more telomeropathy with this keratosis congenita that was a prototype. And you see that with years, we are explaining better patients with ribosome biogenesis or Diamond-Blackfan or Schwarzman disease, as well as GATA2 deficiency. That is also something that might be involved in constitutional disorders. Before speaking about screening, I think that something we are sometimes forgetting is to look on the patients carefully. We really have some physical signs that might be helpful. Someone that has an acquired aplastic anemia would have never ever be a abnormality as a physical exam. The physical exam is perfectly normal. You might observe, of course, some infections in the skin or hemorrhage signs, but nothing related to a constitutional disorder. So most of the time, the acquired aplastic patients are presenting, I would say, healthy. I mean, they look fine. They are tired, of course. They can have some bleeding in the mouth, but they look pretty fine. There is no signs. The development is normal. They have no neurological disorders. The kidneys are okay. All this makes the difference. While when you are facing patients with Fanconi anemia, you see that there is a specific phase from those patients. You have fingers abnormalities, and you can also see some kidneys with very specific presentation that may think about this disease. So I think that it's very important to, of course, look on the patients carefully at the physical exams, because again, you will find some clues to think this is constitutional or this is acquired. The telomeropathy has begin to be very well described. As you can see, this is at the end of the chromosomes. We have many proteins, the chaperone, that are protecting the DNA, and we know that those molecules might be involved in the disease and might, of course, make the patients presenting aplastic anemia. And again, in that kind of disease, when you have some very presenting with very strong presentation, you have some nail dystrophy, you have this hyperpigmentation. This is very important. I remember perfectly a young lady that was supposed to be transplanted with a brother, and when she came in a unit, she had this kind of dirty presentation, and this is really pathognomonic of the sclerosis congenita. And then we made the diagnosis, and you see here the leukoplakia that you can see also when you make the patients open the mouth, and you see all the genes that have been carefully identified in this kind of disease. So, of course, there is Fanconi, there is the sclerosis congenita and telomeropathy, but there is also genes. And I would think that the main importance of my talks will be to present to you this paper in the big lines, not in details, but just to highlight and illustrate the how deep we can be in the diagnosis of patients with aplastic anemia. So basically, the work was done by Jean Soulier team here in Saint-Louis, and it was about almost 200 patients that were tested in Fanconi's lab, so in Jean Soulier's lab, for Fanconi anemia, and they were negative for that kind of presentation. So basically, young patients, you see that this is pediatric patients, median age is 8 years, patients for whom Fanconi anemia has been eliminated, so there is no Fanconi patients in this cohort of patients, but there were strong arguments to say that those patients might be diagnosed with the constitutional disorders. They were young, so when aplastic anemia is presenting in the early ages, this is mostly in favor of constitutional disorders. The screening PNH was negative, and some of the patients have some family-related that were presenting with a disease, or they had some abnormalities in organs, kidneys, cardiac, or so on, that make the physician think that these patients might have a constitutional disorder. So I would not enter into details in the methods, because Jean would be probably more competent than me to speak about that. But basically, it was a WACE approach, and then the identification according to the genes that were getting out. And there was 28 genes that was identified in this situation, and to see if those genes might have a pathogenic role in aplastic anemia and may have explained the pathogenic effect in those patients. And to make a long story short, the abnormality we found in these patients is quite interesting. We were able to basically identify, as you can see, many genes that were not identified so far, many genes outside the Fanconi panel that was responsible for a constitutional marrow disorders. So you can see that there was this SAMD9L, SAMD9 genes that at the moment are creating a lot of noise, because now we have more and more patients, especially young patients, and SAMD9L associated with monosomy 7. So now they are described more and more, and you see that it was not nothing, it was 16 patients who were not Fanconi, was a very high suspicion of inherited disorders. We also identified, of course, telomeropathies. So with some genes that were pathognomonic of this, TERT, TIMF2, RTL1, TERT, PARN, and DKC1. It was about 30% of the patients. And basically, we were also able to find some other genes that are involved in hematopoiesis, and especially GETA2, ERCC6L2, MECM, and so on. So some genes that were involved in hematopoiesis but have not been identified so far to be associated with aplastic anemia. Of course, there is ribosome biogenesis in 14% of the patients, in DNA damage genes outside the Fanconi patients that were also associated with this disease. So as you can see here, that means that when you have a suspicion of a constitutional disorders, you may first of all eliminate Fanconi patients and dyskeratosis congenita, but then you have many genes, as you can see, other genes that might be involved and be responsible for this disease. And on the core of patients, we have about 173 patients that were outside Fanconi, and half of them as a gene that was involved in the disorders that we were identifying. So why it is important? It's very important because, of course, the treatment are different. This is not the main topic of that talk, but as you can see here, the indication for treatment is exactly the same, whatever the disease is, but the type of treatment is different, because for patients with idiopathic aplastic anemia, we are going to give immunosuppression or transplantation if patients are refractory, while for patients with constitutional disorders, we may more going to androgens or transplantation in a CBER, a match unrelated donor is identified. But we are more prone to go to curative treatment than immunosuppression. The other thing that you have to keep in mind, and I always, since I'm speaking about bone marrow failure, I'm always saying this, is that any kind of bone marrow failure disorders, acquired or constitutional, are exposing patients to clonal evolution. So basically, MDS, AML, this is the reason why marrow screening is outstandingly important in those patients. And we do know also that, for example, Fanconi patients, dyskeratosis patients are exposed to cancer and to solid cancer. And we showed with the BMT core of patients that patients who were presenting cancers 20 years after being transplanted were doing worse. So this is really something that we have to follow carefully. So now, the top messages of the talk, and then we will go to very specific clinical presentation. I think that to do a difference between idiopathic and constitutional, when you're with a patient, please ask the disease installation. This is very important. I mean, acquired is always acute. Acquired is always acute. Most of the time, you have CBCs 2 years before that were normal, while constitutional, most of the time, are beginning as moderate aplastic anemia. This is something that at the moment is more and more described in large cohort of patients, showing that very severe presentation and acute is more in favor of acquired disorders, while basically patients who have moderate signs since early ages are more in favor about constitutional. The other thing I told you is really to go deeply with the patients to see if even at very early stage there is some development program. If the physical exam is normal, again, there will no there is any development problems in acquired disorders, no physical problems. While when you have Fanconi or dyskeratosis patients, you may experience these kind of things. The family story is also very important, and especially with those new syndromes, inherited syndromes, and new genes, the family is really important to describe, from the mothers to fathers, but also others family members that may be really helpful, and especially when you have an anticipation, genetic anticipations in some of the presentation. And the other thing that you have to keep in mind is, please don't focus only on blood. Of course, we are hematologists, but we are physicians first, and we have to look for lung problems, liver problems. For example, with glomerulopathy, we have some patients that are presenting lung problems with fibrosis, cirrhosis problem, and they are taking care with liver specialized and blood disorders. And sometimes they have all three together. We don't know at the moment why some patients with the same genes are experiencing this kind of problems, but why some others don't. So this is also something very fascinating that we're exploring at the moment. On the biology, again, when you have a PNH clone, there is a lot of chance that it's not constitutional. A PNH clone is really related to acquired disorders. The immune deficiency is clearly related to constitutional disorders like Fanconi or disc keratosis. This is really something that we are facing at the moment. Most of the time in acquired disorders, the lymphocytes counts are normal. We have also some other markers, biological markers, hemoglobin F or alpha-fetoprotein, when we even don't really know why, but anyway, they are elevated in the context of constitutional disorders. So saying that, just to come to, I think, the main message and what we are doing at the moment in Saint-Louis when we're screening patients, this is our genetic screening, and basically patients that we are referring to genetic screening. So I'm sorry for those guys among you that would like to have some very detailed genetic presentation. This is really, the aim of this talk was really to find out which patients should go to a deep genetic screening when presenting with aplastic anemia. Then the genetic disease details, I mean, we can speak afterwards, but I think that Jean Soulier will probably speak far better than me about that. So here it's described what we are doing. You have aplastic anemia. So again, hypocellular marrow, no abnormal cells. The patients have no other clues for other disease, no fibrosis. You are facing a patient with aplastic anemia. I mean, if he has a PNH clone, at the moment, I'm not saying that we are not trying to find some clues to say if it's yes or no constitutional, but in a way we are mainly thinking it's idiopathic. Then there is two situations. For patients who have no PNH clone. So you see here PNH positive. If PNH is negative, then if the patient has more than 18 years of age, we are really screening the fourth situation. If the patients have normal CBCs in the last 2 years before diagnosis was done, this is extremely in favor of acquired aplastic anemia. And sometimes you may get this information from surgery or sometimes systematic testing for insurance, for example. This is the only interest I find in insurance testing people extensively before getting a contract. I mean, this is something that helps us, or also the work medicine in companies that make us diagnose something that is clearly acute. So this is important. The other thing is the family history. You have to really go to all members to ask for problems, blood problems, but other problems, to see if there is some information that make you think about constitutional disorders. Hemoglobin F and alpha-fetoprotein might also help you. And of course, the physical exam, because again, when you have a idiopathic aplastic anemia, the physical exam is perfectly normal. So you see here that if the patient has I would say, no PNH clone, is an adult, but he has normal CBCs in the last 2 years, he has no family history, hemoglobin F and alpha fetoprotein are normal, the physical exam is normal, then we are considering him as idiopathic aplastic anemia. And so we are giving, of course, immunosuppression if there is no donor available. So in other words, we are not doing genetic testing in these patients. Then, I cannot make my slides going forward. This is the first situation, very easy. The patient is adult, the PNH clone is negative, but you don't have any clues to think about a constitutional disorders. The CBCs were normal 2 years ago. There is no family history. The biological factors you know that are related to constitutional disorders are normal, and the physical exam is normal. We don't go to genetic screening. We go directly to the diagnosis, and then we go to treating. Then the other situation, and it's the most difficult one, and this is the one that we are facing at the moment, is some patients, of course, that are pediatric patients. The patients age less than 18 years. In those patients, the first things that you have to do is clearly to screen for Fanconi, and you have to do the breakage test to eliminate the Fanconi. This is something that is very, very important to eliminate, first of all, Fanconi, that is the first cause of inherited constitutional disorder in this situation. Then there is two situations. If the Fanconi is negative, if the patient is more than 10 years, then we are going to first telomeres NGS to see if there is a telomeropathy or not. This is the first test we are doing before going to the NGS. And if it's negative and we are still facing some clues that are in favor of the constitutional disorders, then we are going to the NGS. On the other situation, honestly, when the patient is less than 10 years and that the Fanconi is negative, we are going to the NGS panel with this genes that I showed you before. And I would say that at the moment, we are more and more for pediatric patients, if there is even one in favor of the constitutional disorders, we are going to the NGS quite quickly. So, of course, this is not always very, as you know, medicine is not black or white. So we have some patients that are adult that are presenting this, meaning that the PNH clone is negative, but you have CBCs that were not normal for a long time. You have some patients have a family history that is difficult to know if it's related or not. Physical exam, you find something, then we are going to first Fanconi, and then if it's negative and we're still facing with this argument to have something, we're going to NGS. And finally, of course, when we are doing all this, if the patient is negative with all the testing we are doing, we are considering that he has an aplastic anemia, and we are then going back to the idiopathic aplastic anemia algorithm for treatment. So, to answer the question that I was asking at the very beginning, who should be screened for aplastic anemia germline mutations? So at the moment, clearly, what we are doing is all patients less than 10 with an aplastic anemia presentation, most of the time, almost all the time, we are testing them. There is something that I forgot to say that is outstandingly important, is that we are doing blood testing, but also fibroblasts. We are doing skin biopsies in those patients because it's always difficult to find mutations as being germline. So this is the reason why we are doing a fibroblast culture and we are testing them. So most of the time it took 3 weeks to this culture, and then 2 to 3 weeks to have the panel. So it's true that sometimes it might be a bit long for patients to wait between 6 and 8 weeks before having the results. This is the reason why the algorithm I showed you before is very useful, because most of the time, if the patient really has no clues to have genetic disorders, we go to treatment and not screening other patients, because if not, we're waiting too much. Then for the patients between 10 and 18, honestly, we are really testing patients that are PNH negative. And if they have some clues to be constitutional disorders with all the things I showed to you before, we are testing first Fanconi and telomeropathy, and then depending on again the clinic and the emergency for treatment, we are testing the other genes. Of course, all patients more than 18 that have a clinical sign that make us think about an inherited disorders. We have a young 32 years patients who were presenting with aplastic anemia, but also with lung fibrosis. It was a telomeropathy. We have this other patient who was presenting with a cancer in the mouth, epithelial cancer, treated with chemotherapy, a drama with toxicity. Of course, we tested for Fanconi. So these kind of things make us test some specific situation, but more or less, this is what we are doing. So NGS for all patients age 10 or less. Targeted NGS for patients between 10 and 18 if Fanconi and telomeropathy and PNH is negative. And if you have, of course, patients presenting with a strong arguments to have inherited disorders, we are testing it. So I think this is it. Yes, and this all the people that are working with me in Saint Louis and that I would like to thank. They are very, of course, active, helpful. We are doing some clinical meetings to discuss those difficult patients, and we are opening this more and more to many centers outside France. So this is Wednesday. It is bi-monthly. I'm going to do some advertisement, but if you have a patient that is difficult, you don't really know how to manage it or to screen it. If you have an NGS, you sometimes find some genes, but you don't know if they are pathogenic or not. I mean, we will be more than happy to discuss. This is a TC like this. It's just a phone, and we're discussing patients. There is most of the time Dr. Sig de Fombrun, Thierry Leblanc, Gérard Saucier, Jean Soulier that are attending, and also our biologist from the telomeropathy side. So sometimes it's very helpful, and we can also welcome some samples and do the screening if you want. So with that, I think that perhaps there were some questions and we could discuss the talks at the end. Okay, so thank you for this question. How we study telomeropathy. So we are basically doing a flow fish in Robert Debré in the Elodie Lenné labs and looking for short telomeres. And basically, this is, I would say, the main screening. And we are also having a NGS panel for telomeropathy genes in Caroline Canengisser labs in Bichat. And we are doing same time. Why? Because we may have some patients that have short telomeres without genes identified. So this is the reason why we are doing this. And then in clinic, if telomeres are okay and there is no genes, we are fine. If telomeres are short and there is a genes, we are fine, because that's what we wanted. I mean, having a disease that is identified and treating it accordingly. And if we have short telomeres, very short telomeres before the 10% percentiles, but no genes, then honestly, most of the time we're considering that as inherited. Of course, there's a panel of argument clinic, all what I said before, but we are considering them as constitutional, and the approach is different. For example, if we're doing transplantation, we are using mainly conditioning with Campass, that we know that is a bit less intensive, more immunosuppressive, and for which we have some, I would say, encouraging results in constitutional disorders. Good to hear you. Good to read you. Between homeopathic and so I would say not really. I mean, we did not find any correlations between the patients and evolution and genotype. What we know, basically, there is two things to say. The first one is that, however, we know that some patients with idiopathic aplastic anemia has some telomeres shorter than others, and without any mutation, because if not, it won't be idiopathic aplastic anemia. So what I can tell you is that those patients that have shorter telomeres in the context of idiopathic aplastic anemia, because again, normally telomeres, it's constitutional and so on. So those patients that have shorter telomeres, have been identified by the NIH. It's a JAMA paper, I think it's 2013 or something like this, as patients that are more prone to evolve to clonal disorders like AML and MDS. So there is no relationship between response or relapse or refractory, but basically those patients seems to be more exposed to a clonal evolution, highlighting again the importance of the follow-up of those patients at the marrow level with cytogenetic.
Mm-hmm. And maybe I have one question. Is there already existing targeted gene panel testing for these different bone marrow failures?
Yeah, so we set up this panel in Saint Louis, and we have about, I think, 160 genes that at the moment are tested for all of our patients. And there's another effort at the national level that is just rising up, and that was a bit stopped by the COVID situation, where we are doing whole exome in patients who are negative for this panel of genes. So the algorithm is really the one that we are testing those 160 genes I showed to you before, because there is Fanconi, there is dyskeratosis, there is all the genes I showed before. And if it's negative, we are now going with families through this research panel that is nationalized, that is at the state level, to identify more genes. But yes, we can instantly do this target panel already.
Thank you very much, Professor Peffault de Latour, for this excellent presentation. And also thank you very much for being our guest speaker. And also thank you to the audience for great scientific discussion. Of course, I would like to invite you to check other upcoming Thursday webinars. You can do it on our website. And please subscribe to our newsletter and follow us on Twitter, LinkedIn, and Facebook. And please also check other webinars available on our EuroBloodNet Edu YouTube channel. Thank you very much and see you next time.